This brief video discussion is about folic acid and folinic acid, corresponding to Antidotes in Depth Chapter A12 in Goldfrank's Toxicologic Emergencies. The learning objective for the session is that you'll be able to name two toxicologic indications for using folic acid or folinic acid as an antidote. Folic acid has a couple of alternate names: pteroyl glutamic acid and vitamin B9. Folinic acid is the biologically active reduced form of folic acid and is also called leucovorin. So both of these products are commercially available, and they serve virtually the same purpose in clinical toxicology, which is to help restore normal folate-dependent intermediary metabolism in cases where other agents are interfering with it. But at least theoretically, leucovorin has an advantage since it doesn't require any metabolic activation step that might be slow or impaired in a patient who's already metabolically stressed. Metabolically stressed from what? The fine details in the figure here depicting the folate cycle aren't especially important, but we need to be able to convert folate first into dihydrofolate, and then through the action of dihydrofolate reductase into tetrahydrofolate to keep this metabolic pathway working, or the cells will suffer injury and start to die. Dihydrofolate reductase can be inhibited, and there are different drugs that do this better in humans, like methotrexate, or in bacteria or in protozoa. Even though trimethoprim and pyrimethamine may be more specific to non-mammalian species, this is only a relative difference, and they can still cause toxicity in humans if present in sufficient quantity, and we might want to be able to reverse this toxicity. Leucovorin, for instance, is used as an antidote for methotrexate, an anti-metabolite chemotherapy drug. Methotrexate may be given in high doses to treat cancer, relying on it killing the rapidly dividing cancer cells more than non-cancerous cells. Systemic methotrexate toxicity is not immediate, and we can reduce the likelihood of these adverse effects occurring with normal cells by giving leucovorin rescue therapy. The leucovorin dose needed can be determined using a nomogram like this, where you plot the serum methotrexate concentration versus the time since its dosing. This is not a nomogram you need to memorize, just to know that it exists and the underlying antidotal concept. The other toxicologic indication for folates is to help detoxify the formic acid created from methanol metabolism into carbon dioxide. Either folic acid or folinic acid may be used for this, and the optimal dosing has not been determined. In my fellowship training, we used a first dose of folinic acid based on the idea that the patient initially would be more metabolically stressed, but this is based on theory and not on hard evidence. Subsequent doses would be folic acid, which is cheaper. The chapter authors recommend IV folic acid 1 to 2 milligrams per kilogram every 4 to 6 hours as long as methanol is present, and recommend a repeat dose be given following hemodialysis, if it's used, since the folate will also be dialyzed away. So that was a lot of buildup for basically just a single slide talking about folate use in methanol poisoning and a best guess dosing regimen. I'll be seeing you around.